Yes, ma'am, you can start now. Yes, ma'am, you can start now.
Good evening, all the guests and the delegates and participants of this program. I welcome you to this curtain raising program for the World Congress on Adult Immunization 2022 on behalf of Indian Society for Adult Immunization. Now I'll directly proceed with the inauguration program as Dr. B.A. Muruganathan is a bit busy. So I would like to welcome Dr. B.A. Muruganathan, our guest of honor. He's an eminent consultant physician and the past president of API. Sir, I would like to have you.
Okay. Can you unmute me? Unmute.
You are absolutely audible, sir.
Yeah, thank you very much. Good evening, my dear brothers and sisters. First of all, I congratulate Dr. Karbakar and Dr. Kale, who had taken the initiative about 3 years back, and we had been trying our hard to inaugurate the society and do a program. But now only the time has come. So, with appreciating those two gentlemen who are behind me to start this adult immunization society. Friends, though we talk a lot of science, we are not doing what we preach. Thanks to COVID, only after COVID, the awareness about vaccination has come. And now there are so many advances in vaccination and the vaccination technology also. So now the first information, all of you, especially healthcare workers, you should have taken the precautionary dose, third dose also. And then for children also, now they've started doses. And yesterday we had an announcement that anybody above 60 years, even without comorbidity, they can take precautionary dose. Coming back to other adult immunization, as a diabetic patient, as a general patient, as a general public, health education is very important about vaccination. Just like lifestyle modification, vaccination is a part of the healthy life. By doing vaccination, you are preventing so many diseases. People think only children you have to vaccinate, but the deaths due to adult diseases are much more, at least 90 times more than the children. So the adults need to be vaccinated. And what are the vaccines you have to take? I think the society will give a printout form, and you can hang those posters in your clinic so that everybody, when they come, the patients know what to take. And the diabetic patients, definitely they have to take 5 major vaccines: influenza, pneumococcal, hepatitis, Tdap, and herpes zoster. These 5 vaccines are important for diabetic patients. Apart from all the other vaccines they should take. Now the new things like HB vaccine, which were bivalent and quadrivalent, now it has become 9-valent. So 9-valent are there in HPV. Same way, the pneumococcal vaccine PCV13 only we have in India. Now PCV15 have come in other countries, and PCV20 has come. So all these updates you should have, and we must make sure the government of India, Randeep Gloria sir is there to recommend all the newer things should also be there. Unfortunately, there is no herpes zoster vaccine now in India. That also we must make sure we get it. As a healthcare worker, our duty as a role model, we must start taking influenza vaccine every year. And if you are above 60, we must also take pneumococcal vaccine. When you take pneumococcal vaccine, you should take conjugate vaccine first, followed by PCV23 after 1 year. And of course, all of us have taken hepatitis B 3 vaccines. And Tdap, the Tdap, at least once in lifetime, you should take Tdap. And once in 10 years, you should take dual antigen of diphtheria and tetanus. So these are the informations which we are giving every time. But unfortunately, all of the doctors, they don't do it. So I am requesting everyone who listen to me, please touch your heart and tell me how many of you have taken Tdap. So you will have to take whatever you are doing, preaching, you must take, not only you make the family members also to do it. So adult immunization, importance and awareness, everyone must start, and everyone should start adult immunization clinic. If you see a pediatrician, they have a very good vaccination center. So how to start an adult immunization clinic? We have guidelines, and you start practicing and also create an awareness among your patients and public. I will request the Indian Adult Immunization Society to talk to the publics through Rotary lines and the press and the television so that everybody knows. So the vaccination becomes very popular. Right now, we always advise if they don't take COVID, please take COVID vaccine. It's high time. And especially healthcare workers, you should take precautionary dose also. Apart from this vaccination, you should also have good hygiene, good water, masking, safe distance. All that we should follow. Vaccination is very important. And always think about prevention rather than treating. So with these few words, I have great pleasure in inaugurating this unique and international conference, which was the dream for my friend Karmakar and Kale. And we were involved in this, and we'll have soon a live program for 2 days. In fact, last 6 months back, I conducted a program for 2 days on all vaccinations, including rabies, including the Japanese encephalitis and things like that. So with this, now I hand over to the Master of Ceremony. Thanks for the opportunity. Take care. Stay safe. Good night.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you very much. Thank you. Thank you.
I would now request our chairperson, Dr. Saurabh Kole, to say a few words and start with the lighting ceremony.
First of all, let me welcome you all. Am I audible now?
Yeah.
Yeah. So welcome all the delegates and the faculty members all over the country and abroad also. Our society, this Indian Society for Adult Immunization, started its journey society, and since then we have organized some small programs on adult immunizations amongst the doctors, and also we have organized programs for the common people regarding the awareness of adult immunization. And just time passes away, but at that time we are not being able to develop it so fast, and we are not being able to establish it in a proper way also. But obviously, after 3 years back, Dr. Muruganathan has come, and he said that okay, we should go it, we should do this, and since then we are trying to do our best regarding this popularization of the adult vaccination and adult immunization. And also we have got the encouragement from the Dr. Apurva Mukherjee also, who have constantly supported, and we are really grateful to them. And the basic idea is that adults also should get vaccination too. And in our college days, always we are heard about this pediatric vaccination, but now definitely this importance of adult immunization has been accepted all over the country. We all know that in NHS, that pneumonia vaccine, influenza vaccine, all these are mandatory. This was known to me even that this has been started probably about 25-30 years back. Why it was started? What is my idea is that in UK, probably they have realized that if we don't give vaccination, adult vaccination, the people will suffer more, and ultimately the more expenditure and ultimately more hospital stay. That's why maybe this has been started all over the country. So now we can understand, particularly after COVID, the importance of adult immunization, adult vaccination, and definitely some sort of awareness already has been established in the common people also. So with these ideas, we have planned to organize this program, that conference on the adult immunization. We have named it as the World Congress of Adult Immunization, because I didn't find any World Congress on adult immunization has been organized so far anywhere in the world. But anyway, I have seen some in the net. I have seen in Barcelona a few years back, there was a conference on the this is the controversies in adult immunization. But Now everywhere this adult immunization is coming up, and many conferences are going all throughout the world. But we have named it as the first World Congress on adult immunization, and we have with us Dr. Reda Sedki. And in future, we need your support to organize this conference in a better way. And we expect that the support and encourage the program, and they will always guide us how we can make the conference a successful way. And many of them have confirmed also. And I'm sure that with you will be grand success. And now I warmly welcome all the participants in enriching experience. So now I would request
You are not audible, Dr. Kole.
we are starting our Saraswati Bandana.
Kurutvam kalyanam arogyam dhana sampadah shubham kurutvam kalyanam arogyam dhana sampadah shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु
Thank you, sir. I would like to welcome Dr. P.S. Karmakar, consultant physician and medicine at Arjikar Medical College and Hospital. He is the organizing secretary. Sir, I would request you to share.
Thank you, Dr. for your nice introduction. Very good evening, distinguished dignitaries and learned audience online. We are here ultimately in inaugural curtain raising program of World Congress on Adult Immunization. It has already been expressed by Dr. Muruganathan before me that this was supposed to be organized in 13th and 14th April 2020, almost 2 years back. But our effort, our hope to organize that conference became shattered by COVID pandemic situations. So here we are again together in a very short form inaugural program for World Congress on Adult Immunization. So we are happy very much to get so many distinguished dignitaries like Dr. Muruganathan, Dr. Sadki, and there are many others, Dr. Eta and many others. So we are really very much thankful to all those distinguished dignitaries for taking some time off to attend our program. And You all know that today is our inaugural program, and we are going to make this event in a bigger way, in a mega event that is in the last week of April of 2022. So I'm really thankful to all the dignitaries as well as the learned guardians who have joined online to make this program a grand success. Good evening and thankful to you all. Now I hand over the digital podium to Dr. Devdatta for the next proceeding. Thank you very much.
Thank you, sir. So I would like to proceed on with our sessions. The very first session is on adult immunization, a global perspective by Dr. Reda Sarki, and the session will be chaired by Dr. Shatabdi Mitra. She is a very known face to us. She is currently working as the assistant professor cum epidemiologist in the Department of Community Medicine of KPC Medical College and Hospital. She has a wide experience of teaching, training, research, and patient care services. She is a national level trainer of non-communicable diseases, immunization and leprosy, and state level trainer in geriatric health and mental health. She has published more than 14 research articles in different national and international journals with more than 250 citations and working as reviewer of different journals. Dr. Shatabdi is also working for medical education, and she is an active member of Medical Education Unit and Medical Education Society of India, besides IPHA and IAPSM. She has completed fellowship in vector-borne diseases from London School of Hygiene and Public Health in 2019. She has presented papers in different national and international conferences and was awarded with Ford Foundation for research proposal. Currently, she is working with geriatric mental health, diabetes-related complications, and non-communicable diseases. I would like Dr. Shatabdi Mitra to take over the session. Thank you.
Thank you, Dr. Devdatta, for the nice introduction for me. In this session, I am here to be privileged to have Dr. Reda Sarki. I am going to introduce her. Dr. Reda Sarki is chief executive with lifelong experience in forging multidisciplinary terms to invent and execute new ways to lead change. He is the founder and president of the prestigious Geneva Learning Foundation and chief learning officer of Learning Strategies International. Reda has worked for the United States, United Nations, primarily for the World Health Organizations and at the International Federation of Red Cross and Red Crescent Societies. Over a decade ago, he partnered with the global learning leaders to explore how to transform digital learning for the Red Cross and Red Crescents. 13 million volunteers and 5 lakh staff over 190 countries. Starting in 2016, Reda led the development of what had become, by January 2019, the world's largest and fastest growing digital health network of immunization professionals. When the COVID-19 pandemic hit, this digital health infrastructure enabled the development of the COVID-19 PR Hub to support rapid response and collaboration across the health system levels and borders by professionals to mitigate the shock of the pandemic on immunization services, to respond to the root causes of vaccine hesitancy, and to strengthen the resilience for the service recovery. Reda's vision today is that the COVID-19 pandemic has created an opportunity for a digital-first renaissance in global health. He believes that the next 20 years of public health are likely to be about harnessing the digital transformation through hybrid networks, fusing digital and physical in ways that can help not only deliver knowledge, not only deliver health, but actually transform health outcomes. Learning how to develop people by digital means is a vital investment for the promise of digital health to be realized. So let's get highlighted, enlightened ourselves and all the participants from Dr. Rita. Sir, please.
Thank you very much, Dr. Mitra, distinguished speakers and leaders of immunization in India and everywhere else, given this is a World Congress on Adult Immunization. I'm going to go perhaps very quickly, and this presentation may not look like a conventional presentation suitable for a World Congress. Some of you may even be surprised or I hope not offended, but and one of the ways in which it is going to be different is that you'll be hearing music and perhaps other sounds as we go. So first of all, I'd like to say this is very timely. I think there's a small technical glitch, as always happens, of course. This is very timely because Immunization Agenda 2030, so the strategy adopted by all of the member states of the World Health Organization, as you know, places as one of the key strategic priority for life course and integration, with the goal that all people benefit from recommended immunizations throughout the life course, effectively integrated with other essential services. However, the story I'm going to tell you will show that it's not so easy. And in fact, recently I had a chat with someone from the headquarters of the World Health Organization, one of the people responsible at the global level for life course and integration, who said, what can we do to get more interest from professionals who work in immunization in this question? So that is one of the questions that I'll be trying to answer. Now, our work since the 29th of April, so World Immunization Week 2021, has focused on this question, really thinking about the future of immunization. And at least for this decade, it's focused on Immunization Agenda 2030. Now, just if you can easily, if you don't get everything you want from this presentation, if you'd like to know more, just look up the Geneva Learning Foundation or my name, and I welcome, happy to connect with you and encourage you to connect with the foundation. Another thing is, one of the things we're experimenting with, and this is part of our mission to find new ways to learn and lead, is really to, we're now offering a podcast, and I encourage you to go look at that if you'd like to know more about our work. Now, very brief introduction to the foundation's work. We develop a number of programs. It's about transforming how we learn and lead. The basic change in the model is shifting from old learning, where you have a teacher at the center addressing the students, transmitting information to the students, going to a new learning model in which teachers are learners and learners are teachers, connected to each other around this hub and spokes where everyone is connecting with everyone else. Here at the right, you see one of the main theoretical models and frameworks that we rely on from Bill Cope and Mary Colensis, which is really an agenda for new learning and assessment. What that means in practice, for example, in our partnership with the World Health Organization, we've developed already, I think to this day, we're now at the 30th. We're currently running the 30th cohort. The last 4 or 5 cohorts have been specifically on Immunization Agenda 2030. And one course in particular really helped immunization professionals look at this question of life course and integration. Now, with the first evaluation in January 2019, this is what we found. These are more than just courses. These are interventions designed to foster and improve practice at every level. Together with, in fact, Dr. Mitra, other scholars from India and 56 other countries, we then built what we call the Impact Accelerator, a new kind of system to help immunization professionals tackle difficult questions and lead change, including this change from where we are now with vaccination focused primarily on small children to a more complex but also more valuable and more productive immunization system that looks at immunization all along the life course. We found that this system, for example, within 6 months could produce startling results where we saw that people who engaged through this impact accelerator were in fact able to lead change far more quickly, with almost an 8x difference. We're 8 times more likely to actually develop a meaningful, tangible project around their needs, their challenges at the local level, wherever they work, and actually take that project forward. So where we are today is, as of this morning, our platform connects 43,981 immunization professionals. And again, in this decentralized model, it is not only about what we, as the Geneva Learning Foundation, transmit to practitioners, it is also very much about practitioners sharing with each other. On the 29th of April 2021, you can see here the 2 top global people from UNICEF and WHO respectively, Dr. Robert Nandy and Dr. Anne Lindstrand, who met with over 5,000 immunization professionals in an online event from basically all over the world. And they were there to present Immunization Agenda 2030, but they were also there to listen to the challenges. And I would like to say that life course and integration was cited as one of the top challenges, but it was not. And I think this is one of the many reasons why I see this particular event, the World Congress that you are organizing starting today or kicking off starting today, as a key event, because right now the perspective of life course and integration is not at the top of the agenda. It is very prominent in SP4 of Immunization Agenda 2030, but I believe, my conviction is that it is the movement, the mobilization of professionals like yourselves who will be in the coming weeks, months, and years making the difference, putting this question at the heart of everything that happens in immunization. This question of how we lead change in immunization, for a long time, maybe we did not really need to ask it. Immunization was one of the few interventions in global development that actually worked, where we could line up the kids in the village and they stopped dying stupid deaths from diseases that no one should be affected by, much less die from. Now we have a more complex environment of obviously a changing world, and therefore it is necessary. We feel that there is an imperative to move again, to mobilize again around questions that are new, to advocate for change in respectful, constructive ways, but change is certainly needed. So on the 7th of March, and you can see here so the sort of slogan and banner, this call to join the movement for immunization. This is not, kind of just activist or rabble-rouser movement. This is a movement called for by the Director General of the World Health Organization at the 74th World Assembly, calling for a broad social movement for immunization that will ensure that immunization remains high on global and regional health agendas and help to generate a groundswell of support or social movement for immunization. Now, this movement is larger than any one individual or organization, but I believe an event like this World Congress is positioned and uniquely positioned to contribute to that specific question, a strategic priority of Immunization Agenda 2030, that despite the recognition of science that it is an important question, has not yet been translated into policy practice. That is why we need initiatives like yours in order to help build and propel this movement, and to make sure that all of the questions that matter, all of the questions that can make a difference, can actually just be part of this movement for change, to make sure we can achieve the global goals of Immunization Agenda 2030. What's at stake? The estimate by the World Health Organization is that achieving the goals, including strategic priority 4, life course and integration, will save 50 million lives. That is the estimate from WHO. So again, through this World Congress, you are contributing to a critical question that is part of this broader movement to save lives. Now, at the Geneva Learning Foundation, our contribution, we look at education, we come through the door of education, and we've been working across a number of areas, across medicine and public health, as well as humanitarian response. We've developed an approach called the full learning cycle, and on the 7th of March, our launch, our contribution to the movement was to call for immunization professionals to join what we call a full learning cycle. 6,319 professionals responded to this call, and of those, 151 were from India. You can see the list here of all the countries involved. You can see that still many countries have one sole representative. India is number 4 in the ranking. It is not a ranking, but it is a reflection of the extent to which there were immunization professionals at that point in time who were already ready to respond to the call. The call is still very much open, even though the movement has now been launched, as we progress through this continuum of action from knowledge to impact. Now, you may ask, what is this full learning cycle? What is it about? What is the curriculum? What is the content? Well, we flipped on its head the logic of content being pushed from Geneva or Washington or London or Seattle to people in countries. And instead, we are asking you the question. You work in immunization every day, whether you are in the health facility, whether you are in a district, a region, or working at the central level with the Ministry of Health. And so we asked you, what are the challenges that matter to you? And every person who applied to join the movement responded to over 95 questions, including the questions to identify their biggest challenges. And again, life course and integration, adult immunization was not in the top reasons, despite its recognized importance. Right now, what this gives us is a picture of how much work remains to be done, and therefore how important events and initiatives such as yours are to the recognition of this strategic priority, that this is indeed a strategic priority. Now, in the full learning cycle, we have launched what we call the Ideas Engine. I'm going to very quickly tell you more about that and invite you to go look, see for yourself. And of course, call on you to, if you find this compelling, if you see this as a potentially useful way to strengthen the work that you are doing, to join this movement for Immunization Agenda 2030. The Geneva Learning Foundation, will be offering 3 levels of certification for the different components of the full learning cycle. And there is very much a modular approach where every participant decides where, when, and how, and where they want to engage in order to gain the greatest benefit that will help them, that will help you in your daily work. Dr. Godwin Mindra from UNICEF made the point that in this, even though there are people from all levels of the health system, we are at a juncture where the difference is going to be made. The point of contact, where the rubber hits the road, will be where those of you who have direct contact with the communities are going to use new ways to do new things, and that is all about reaching the unreached. Kate O'Brien, the director of immunization at WHO, we need people to feel like they have the authority and are empowered to lead change in their community, in their program, at the most local level, understanding what the goal is and what the targets are. And that means that if someone who is working at one of the so-called lower levels recognizes the significance and importance of adult education, they should be adult vaccination, they should be supported. They should be that initiative, the willingness to integrate adult vaccination into the ongoing program historically focused on children needs to be recognized and supported rather than shunned or seen as something that threatens the existing way that things are done. Now, what does this movement mean in practice and what has it generated? We've seen incredible levels of motivation, excitement, and enthusiasm. And this is from Asad Ali, who is in Pakistan. And even though he is obviously very busy, he takes time to actually let us know. He says, I'm in a mountainous region of Pakistan on the COVID-19 vaccination surveillance and monitoring mission. And he has the kindness to let us know when he will be back. That is how committed he is to contributing to the global movement, even as he continues to do his daily work. And this is from Afghanistan. And Syed writes and says, very simply, only one line. We asked him if he was ready to join and to contribute and to begin the activities of the full learning cycle. And you can see his response here. It is just one line, but it is quite eloquent. From an immunization professional and a doctor, he says, yes, I am ready to rock. Now, what do we actually do in this full learning cycle, and how could this be helpful to you and others who are leading the change needed to have adult immunization recognized and integrated into existing immunization programs in India and elsewhere. First example of the first component, what we started with on March the 7th, was the ideas engine. And what this is across these 7 strategic priorities of Immunization Agenda 2030. You can see there's one here, SP4. This is the one that every one of you can contribute to, and also go and look at the ideas and practices that are being shared from participants across the world. It is as simple as clicking a button, and in the first 10 days of the movement, 764 ideas and practices were submitted from 62 countries. And this came from 671 scholars, practitioners who shared these, including a small but significant number of ideas focused on SP4, on life course and integration. Now, again, the ideas and practices by country, you can see the list here, which countries contributed more. And I'm proud to say and report that India shared 27 ideas and practices, 3.5% of the total. Now, before I go any further, this idea, yes, and this is a quote from a participant. I encourage you the Ideas Engine is open to all members of the Movement for Immunization Agenda 2030. It is a public good that we offer the structure, but it is being filled by practitioners from all over the world. So if you want to see what is being done, what are the practices, what are the ideas in other parts of the world, that is what is offered through the Ideas Engine. I'd like to mention another initiative that is part of this movement for Immunization Agenda 2030, and that is Teach to Reach. For the first time on the 17th of June, we're going to be opening up Teach to Reach, which historically was a networking event reserved for immunization professionals. And for the first time, professionals from other areas of health are going to be welcome to join. This makes it relevant because life course and integration requires a more integrated approach. We cannot continue to work in silos. And just to give you an indication of the scale on which these networking events, this Teach to Reach happens, the last Teach to Reach on 4th of March saw more than 8,500 immunization professionals from all over the world connect and support and meet and learn together. Now, what's the point? What's the value of this and other activities in the Movement for Immunization Agenda 2030? You can see one quote here. I had the privilege to interact with very highly qualified, internationally recognized health professionals. It's like an opportunity to dine with the creme de la creme of global health. And the second quote from someone who is probably closer to the ground and works in a rural area and who's been wrestling with vaccine hesitancy, and who says, after Teach to Reach Connect, I have evidence to convince any resistant people. This event was amazing to me. Of course, if you work in public health, you're asking, well, okay, what's the impact of this? Where's the evidence that this is actually making a difference? We can spend time talking to each other, connecting with each other, but so what? And so on the so what, we're using an evidence-based scale tracking, not only taking the temperature of what is happening throughout the movement with people, individuals reporting to each other and to us what difference it's making in terms of a gain in confidence. If you're going to go advocate that adult immunization needs to be a focus of your immunization program, you need to have the confidence to do it. If you are going to consider changing how the existing system that is entirely focused on children needs to expand to teenage girls, to adults at different points in the life course, you're going to need motivation. And you can, of course, rely on the ideas of colleagues who are right there, your immediate colleagues. And of course, they're the ones you work with every day. They're very important. But this idea of a global support system, imagine if all of a sudden you can benefit from the inputs, the ideas, the practices of thousands of other fellow immunization professionals from all over the world. That is the power of this approach and the potential of this movement. After participating, I thought I need to find out more technical details about my country's program. So this is someone working in the health facility who all of a sudden, rather than waiting to be told, do this, do that, may go look at the country's program, see that adult immunization is already part of the story, and say, how come we're not doing it? So imagine that kind of local initiative. If all of a sudden people at every level of the health system are speaking to each other, connected to each other, and this is not a dream, this is what we're doing every day in the movement, and this is what we have done since the COVID-19 pandemic came and we created what we call the COVID-19 Peer Hub. So again, to finish, this is about the need for change and recognizing that leading change in a globalized, hyper-connected world cannot happen in isolation. We simply cannot continue to do things, learn things, and lead change in the ways that we have before. Last but not least, you can see the QR code here. If you'd like to experience this is again a testimonial from a participant. Every Monday we have an assembly. You do have to apply to join the movement. It is actually closed, but I'd like to, on an exceptional basis, we'd be honored to have members of the World Congress join us. It is every Monday, so the next one is actually happening tomorrow it is quite late Indian time because it is 5 p.m. Geneva, so I believe that would be 8:30 p.m. Indian Standard Time. Thank you very much. I think I apologize if I have been over time. I hope that Dr. Mitra will forgive me for that. And others.
Thank you, Dr. Reda. Thank you, Dr. Reda Satke. So we have learned so much today, and the immunization agenda 2030 for integrated approach, so that we hope in future we will work together more, so that the adult immunization, the overall immunization, will be able to show a new hope. Thank you so much. Now I'd like to hand over to Dr. Devdatta.
Thank you, Dr. Reda. It was a lovely session, a very informative one and an elaborate one as well. Got a chance to learn a lot from the session. Thank you, Dr. Shatabdi Mitra, for sharing the session. Now I would like to proceed on to the next session. That is by Dr. Reena Ghosh. It is on need for adult immunization. And the session will be chaired by Dr. Tanuraj Sirohi. And Dr. Sirohi, he's already here. He's an intensivist and internist at Meerut, and he's also a professor of medicine at Shuharti Medical College. He's an instructor for ACLS, BLS, FCCS courses, director of Hope Hospital, and he is the president of IACCM Meerut branch. Dr. Sirohi, I would like to welcome you to chair the session for Dr. Reena Ghosh.
Thank you, Dr. Devdatta. It is a pleasure and honor both for me to be the part of the World Congress on adult immunization. I am really thankful from bottom of my heart to Dr. Kohli, who has given me the opportunity, and it is a great occasion to introduce ma'am of such a great stature. She will be talking on need for adult immunization. Dr. Reena Ghosh is from Calcutta. She is consultant pediatrician attached to the Institute of Child Health, Calcutta, and she's in charge of immunization of the said hospital. She is trained in advanced vaccinology. She has many publications, both national and international. To her credit, she is one of the investigators in multicentric clinical trials on vaccines such as rotaviruses, measles, rubella, typhoid, hepatitis A, H1N1 influenza, pentavalent, hexavalent, etc. Immunization chapter contributed by her in medical textbook known as Handbook of Medical Practice. She is member of West Bengal Calcutta district event following immunizations, very important part of Immunization. She has been invited as speaker and chairperson in many conferences and workshops. Just mentioning a few of them, she has participated as a faculty in international workshop on opportunities and challenges for the new vaccines and organized by the International Vaccines Access Center, IVAC of Johns Hopkins Bloomberg School of Public Health. This is a great achievement. I must compliment her. The other, just to mention, is conducted pre-conference CME National Conference IAPS MCOM in 2017. Newer vaccine and vaccines update held in the Science City of Calcutta. Over to Dr. Reena ma'am for her presentation.
Thank you, respected Chairperson, Dr. Tunraj Shirohi, for introducing me. Good evening, everybody. This is my privilege to receive the invitation from organizers of Indian Society of Adult Immunization to share my views on need of adult immunization. Although immunization has become a centerpiece of routine pediatric medical visits, it has not yet been well integrated into routine healthcare visits for adults. In fact, adult immunization is in its infancy, not only in India, but even in the most developed countries of the world. Only after corona pandemic hit in 2020, now people has become somewhat aware of the adult immunization. I will start with the famous quote of William Fudge's, that is, vaccines are tugboats of preventive health. William Fudge's was a great epidemiologist and formulated the design for smallpox eradication. He is one of the great epidemiologists. So with this famous quote, I will go to the need for adult immunization. So adults, actually, it constitute 60% of our population. And this adult population, except the elderly one, it constitutes the most economically productive age group. If they fall in because of the vaccine preventable diseases, this is a great loss for a country. This vaccination or immunization for adults is one of the most convenient and safest preventive care measures in all age groups. It saves lives, improve health, and ensure long-term prosperity. They boost development both through direct medical savings, indirect economic benefits, educational attainment, labor productivity, income savings, and investment. So let us know about the burden of the adult diseases. There is very little data regarding the burden of the adult diseases. So actually, only in the US, there is some work. There is in 2015, there was 14.1 million cases of vaccine preventable diseases attributable to unvaccinated adults, which incurs an economic burden of approximately $9 billion in that single year of 2015. It is well to know that US administered at least 10 vaccines above the age of 19 years. Unvaccinated individuals are responsible for almost 80%, that is the $7.1 billion of the financial loss. So this highlights very well the magnitude of the burden, and there lies the value and importance of the adult vaccinations, which can benefit our economy very much. So the positive health impacts for vaccination include reduced mortality and morbidity These are well recognized. But the economic burden from people who are not getting vaccinated, this is not easily recognized by the society. This burden includes unexpected increases in health expenditure, lost income as a result of reduced functional capacity. Now let us see what is the burden in India. Actually, there is no data. There is no data of the Indian population as such, but there is an estimated population of 63 million people in India, which are pushed to poverty because of the health expenses each year. And population growth and increasing life expectancy call for effective healthy aging strategies, inclusive of immunization, to reduce the burden of BPDs. Now, the burden of adult population, this is increasing day by day. It has been estimated that by 2050, the world population of adults aged 65 years and older will be more than double. That is from 700 million in 2018 to over 1.5 billion people. And global life expectancy is also increasing. It is rising from 61.7% to 72.6% in 2019. So, to keep such a huge adult population healthy and to offer them good quality of life, we have to give vaccination to prevent the vaccine preventable diseases. So what are the other needs for adult immunization? We always find a pool of unvaccinated adults in our community who were never been vaccinated in their childhood and they did not contract any natural diseases. So they remain unvaccinated and susceptible for the vaccine preventable diseases. And when they contract the PPD, they can transmit it to the other susceptible population. And there is waning immunity. It is not that the vaccine once given, it will last for lifetime. Some of the vaccines, after a period of 10 to 12 years or 15 years, the immunity started waning. So, vaccination which they received in childhood, when they reach the adolescent or adulthood, young adults, they become susceptible to the vaccine preventable diseases. It has been observed that in Soviet Russia, there was a huge outbreak of diphtheria and which has resulted in a lot of deaths in the young adults. Next is...
Excuse me, ma'am. Dr. Reena.
Yes.
Dr. Reena, this is Sonal here. Ma'am, we are unable to see your slides. I would request you to re-share these slides, if you don't mind.
Okay.
Yeah.
Are you able to see now? Do you able to see?
Not as of, no, not as of, ma'am. I would suggest you can, now it's completely visible.
Yes, yes.
Now it's visible.
Yes.
Now we see.
Jignesh, can you confirm?
Now?
Can we see the slides?
Now we see.
Yes.
Can you?
Yeah.
Yes, ma'am.
Sorry, ma'am, for interrupting you, but then now you can take it forward.
Okay. Because the slide sharing is very important. You have to see the slides as well. So I will start with this slide. So the pool of unvaccinated adults, then waning immunity, and the next is epidemiological shift. Actually, there is an epidemiological shift of the many diseases which is documented. One of the important is which has been observed in Greece. In Greece in 1975, they have started giving the MMR vaccine from 1-year-old children, but there was a 50 to 60% coverage, which has resulted in when these population, they become adults, the women, they do not have the, some of them do not have the immunity from the rubella. So it has been observed in 1993 that in Greece is having the highest number of CRS in the world. And another reasons for need for adult immunization is that as the vaccine and vaccine recommendations evolved throughout time, newer vaccines are coming out every day. So their recommendations are changing. So it may be so that when that particular child, that time the newer vaccines were not available, so they have reached the adulthood. Now they can also receive these vaccines if recommended as a catch-up vaccination. And also there are increased risk factors which come with age, travel, and profession. That is, the healthcare workers are they are very much susceptible for the some of the infectious diseases like the hepatitis B, varicella, etc. So what are the benefits and impacts of adult immunization? It will definitely reduce the infectious diseases in the adult population. And also the unvaccinated adults, they can spread diseases to infants as well, who have not yet been unimmunized. The most example is that pertussis. As because the pertussis is not transferred to the neonate from the mother, pertussis antibody is not transferred to the neonate from the mother, the newborn remains susceptible to get the pertussis. So if surrounding all the members, adult members, if they are vaccinated with pertussis vaccine, this is the way we can prevent the pertussis in neonate. And also the maternal immunization with Tdap also will reduce neonatal pertussis. And the next is the reduction of the emergence of the antimicrobial resistance. As we all know, some of very important example is pneumococcal vaccine, which has reduced the antimicrobial resistance against the bacterial diseases very much. And also there is example of Haemophilus influenzae type B, which has also reduced the antimicrobial resistance. And some of the viral vaccines like measles vaccine and influenza vaccines, they have also reduced the uses of the antibiotic. And also the significant progress has been made to produce the vaccines against other non-infectious diseases. Conventionally, vaccines we think is against only the infectious diseases, but there are significant progress against the non-infectious diseases like cancer, autoimmune diseases, and chronic infections. The most important examples of chronic infections are hepatitis B infection. When it stays for a long time, it can lead to hepatocellular carcinoma. And another is HPV vaccine. HPV vaccine contracted can lead to cervical cancer, and it is very much well documented. And another benefit is that the mass immunization is a known strategy to contain, control, and eliminate disease. This is the example of COVID-19 vaccine, which has definitely will agree that it has contained the somewhat the corona pandemic. One of the important aspect of maternal immunization is the adult immunization is maternal immunization. Maternal immunization, it protects both mother and baby and hence bridges both childhood and adult vaccination. It passively transfers the antibody to the neonate. Thus, it protects the tetanus, pertussis. And elimination of the maternal and neonatal tetanus is one of the most successful maternal immunization protocols. Immunization for international travelers. Now, people are moving to different countries for various reasons. For many reasons, for job purposes, for treatment purposes, there are many reasons they are moving very much to the international travelers. So travelers visiting other countries, there is a potential risk for contracting some of the infectious diseases, and recommendations depend on the region, country which they are visiting, and their duration of trip and the nature of conditions of the travel. One known important vaccine we all know, that is the yellow fever vaccine, then oral poliovirus vaccine, and there are many other vaccines which are recommended for international travelers. And recently, the travelers who are going to some university for their further studies, they have to take specified vaccinations which are being laid down particularly by that university only. Now, there are the challenges of the adult vaccination. So there are lack of knowledge, both the patients and the providers. And I will give you some example that the provider, they are giving the vaccine without knowing the in-depth knowledge of the vaccination. And their prescriber also, they are writing the vaccines which are not matching with the recommended vaccination schedule. So there is a lack of knowledge for both on the patients and also the providers and also the prescribers in some places. And there is a poor public health and private infrastructure for vaccine delivery. Really, there is a country-specific immunization schedule, although the CDC has come with a definite immunization schedule for routine immunization of adults and as well as for the disease conditions. But actually, country-specific immunization schedule is still lacking. And one forbidden thing is the high cost of the vaccine. You know that the HPV vaccine, which is monovalent vaccine, is costing 10,000 rupees in India. So it is really a very much unaffordable for the, at least for the many of the public. And lack of availability of the vaccine, sometimes it causes problem for the proper adult immunization. So it will help the vaccine manufacturers will come up with great zeal so that they can manufacture more and more vaccines to cater such a huge amount of adult population. So what should be the guidelines for the immunization practice standards in adult population? It involves a lot of processes whom to vaccinate. Because adult population whom to vaccinate, these are selective. They will need the selective vaccines. Not all vaccines to be administered to each age group of the vaccine. So it will be selective. Some vaccines will be administered to some and some will not be administered to others. Like the elderly will get the pneumococcal vaccine, and influenza vaccine can be given in high risk group. Who are getting the spleen operation, that is before splenectomy, they have to be given to the meningococcal conjugate vaccine, pneumococcal vaccine, and hip vaccine. So it involves the disease process for which they are getting the vaccine, and the age, and there are a lot of other factors also. The next problem is where to vaccinate. There comes the question of adult vaccination. Where to it, lot of providers, lot of the beneficiaries, they move from here to here to there, that where to get these vaccines. So that is really a problem. There should be some designated adult vaccination clinic. Now we have to establish in this World Congress so that people have got knowledge that where they can get the vaccination. Next important thing is to assess the vaccine contraindications and precautions. And we have to provide the vaccine information statements to them. Ensuring that the appropriate storage and handling of the vaccines are to be maintained properly. We know that if the vaccines are not maintained in proper cold chain, the vaccine efficacy will be lost and the vaccine will not work. Last but not the least, is the reporting of the AEFI. Adverse event following immunization. Many a time I have seen that they have faced with some, the provider knows that this is a AEFI, but they fear to report it. They said that, no, I will be caught. It is not that. We want to know what are the events has been followed after the vaccination. It has to be investigated whether actually it is due to the vaccine or not. In that case, if it is a new vaccine, we have to take proper precaution, whether we have to continue the vaccine or you have to disrupt the vaccine. So there are, but the adult, this is AEFI reporting very poor. I do not know, at least in our country. So adult vaccination clinic has to be established. It is now well understood thing. Then whether it is individual or in the community level, on which factor it is, what are the determining factors? Vaccination in public health is done in the best interest of the community. It is done usually in the government program, as we have seen in the this corona vaccine. And goal is to control the health of infectious diseases. Then how to improve the adult immunization? We have to create awareness, not only amongst the beneficiaries, but amongst the providers also. We have to highlight the burden of the vaccine preventable diseases. And we have to summarize the vaccine recommendation. What is the vaccine recommendation in our country? Our Indian society has come out with some recommendation, but that is not very clear. It should be very clear, and it should be there should be some one specific recommendation in each country. So we have to find out some solutions. How can we solve all these problems? So in this Congress, we'll find out some solutions. So we'll discuss in some other forum. So to summarize, adult vaccination is a promising strategy for improving quality of life by reducing the health consequences of the vaccine preventable diseases, waning immunity from childhood vaccines, change in target age groups for many vaccine preventable diseases, extensive travel, stressful lifestyles, and neglect of prevention has led to the increasing burden of BPD amongst adults. Thank you so much.
Thank you very much, Dr. Reena Ghosh, for enlightening us about basically on the Indian perspective and the creating about the awareness and the need of the Indian immunization policies. This was a really very good narrative and insight of what best we are doing and what better we can do in the coming times. You have very nicely spoken about the burden of the disease of in the Indian data, which is, I think, and as you rightly said, is still incomplete, which will have a great impact on the health care impact and the economic impact on the society as well. You very rightly enlightened us about the maternal immunization, and you have very clearly advised about what are the diseases which should be taken care of, about traveling when you are traveling, especially the traveling advisory to the people of high risk group, elderly people, and especially with who carry high risk challenges. You have also spoken about the challenges about basically the lack of knowledge and the place where you can get the immunization. Thank you very much, ma'am, for enlightening us, especially the Indian narrative where we lack, what are the weaknesses and what are the strengths. Thank you very much for the time given and the enlightening lecture given by you. Over to Dr. Devadatta.
Thank you, ma'am. It was a very elaborate session and we got a lot to learn from it, especially the parts which you emphasized on the adult immunization clinic. Thank you, sir. Thank you, Tanuraj Shiroi, sir. Thank you, ma'am. Thank you. I would like to proceed on with the next session. The next session was to be, the speaker has not yet arrived, and we have to postpone the next session. So we are continuing with the next session, that is the panel discussion. And I would like to hand over the proceedings to Dr. Ribhu Basu, an eminent public health specialist and associate professor of community medicine, Bankura Shammilani Medical College and Hospital, to moderate the panel discussion on bare minimum vaccines for adults.
Hello, Dr. Ribhu Basu is here.
Good morning. Good evening, everyone. Thank you, Dr. Haldar, for introducing me. So now I would like to request or invite our chairperson, Prashanto Kormokar sir, to please start the proceedings of the panel discussion. Prashanto sir, please.
Thank you, Dr. Ribhu Basu. Am I audible?
Yes, sir.
Yeah. So now we have come to a very important session, that is panel discussion, and that is on bare minimum vaccines for adults. So really, we are still far away from to reach our goal. So far, adult immunization is concerned, and here we are having so many important dignitaries, so many important names in our panelists. And I like to invite them, and I will hand over the to a moderator, ultimately Dr. Ribhu Basu, to take up the questions, to put questions to our panelists. So we do have very important personalities like Dr. Dibyendu Banerjee and Dr. Indrajit Tiwari, Dr. Pranit Ghosh, Dr. Anup Kakureja. Dr. Dibyendu Banerjee, please. Are you here?
Yeah. Good evening.
Good evening, sir, for making time to be present over here. And Dr. Harivansh Chopra. Dr. Harivansh Chopra, are you here?
Good evening. Good evening. I am here.
Good evening, sir. Good evening. And Dr. Indrajit Tiwari.
Yeah. Good evening, everybody. Good evening, everybody.
Good
I am
evening,
here.
sir. Good evening. And Dr. Pranit Ghosh.
Yeah. Good evening. Yeah.
Good evening, sir. And Dr. Anit Kukreja.
Sir, Kukreja sir, due to some urgent matters, cannot come today. Okay, so we shall be doing the panel with 4 speakers. Okay, sir.
Okay, only 4 panelists we do have. So I like to invite Dr. Ribhu Basu, who is associate professor in Bankura Shammilani Medical College, and he is one of the important person who is having keen interest in adult immunizations, and he has many national and publications in national and international journals. So I like to have Dr. Ribhu Basu to set the ball rolling. So far, our panel discussion is concerned on bare minimum vaccines for adults.
Thank you.
Over to Dr. Ribhu Basu.
So I shall now introduce Dr. Dibyendu Banerjee, who is a consultant gynecologist, and in Bhagirathi Neotia Women and Child Care Center in Colombia, Asia. He is the president of Bengal Obstetric and Gynecology Society from 2019 to 2020, and currently he is the president of Rotary Calcutta Kakurgachi branch and director of Anukaran Fertility. So welcome Dr. Dibyendu Banerjee to this esteemed forum.
Good evening.
Good evening, sir. Now I would like to introduce Professor Harivansh Chopra to you, who is the professor, Department of Community Medicine, and he is currently the president of Indian Association of Preventive and Social Medicine, and he is a public health expert. So I would also like to introduce Dr. Pranit Ghosh. Dr. Pranit Ghosh, can you switch on your camera, please?
Yeah.
Okay. So Dr. Pranit Ghosh is a public health professional by training. He is an alumni of Medical College, Calcutta, and completed post-graduation from AIHPH, Kolkata. He has been involved in various projects, and currently he is working as a scientist E in ICMR RMRC Dibrugarh after 15 years of teaching. So welcome, Dr. Promit Ghosh.
Good evening.
Okay. Now I would like to introduce to you Dr. Indrajit Tiwari. He is the head of gastrocritical care and liver transplant units, Apollo, Kolkata. He has managed the highest number of liver transplant patients as a chief intensivist in eastern part of India. He is also leading the adult immunization program at Apollo, Kolkata. So welcome, Dr. Indrajit Tiwari. You shall be an asset to this discussion. Thank you, sir. And we would miss out on a very important person, that is the chairperson himself. So we must not forget to introduce him also. So Professor Partho S. Kormokar, he has more than 35 publications to his name, co-authored several books, and he has been awarded fellowships in prestigious Fellowship of Indian College of Physicians, Fellow of American College of Physicians, and Fellow of Royal College of Physicians. So welcome to the session, Partho sir.
Okay.
So
thank you. Okay, you please proceed with the question and answer.
Okay. So with these introductions, I am now proceeding with the panel discussion. So we shall keep it in a very coffee table discussion, and obviously we are trying to record your important opinions so that we can make a consensus statement and circulate it to the government officials for advocacy of adult immunization. So firstly, I would like to ask Dr. Promit Ghosh that why do you think that vaccination is important for adults? And can you tell us some evidence regarding this decision?
Thank you. I thank the organizer for inviting me in this panel discussion. Before this panel discussion, we have a very informative session by Dr. Reena Ghosh. I think Madam already explained, in detail about the need of adult vaccination, especially in India and other countries. So what I feel, or the more or less the evidence shows that in India, we are thinking that we are heading towards we call it silver tsunami. That means our adult population is increasing and day by day. And maybe in 10 to 20 years, maybe down the line, it will be more than two-folds of what it is today. So this adult population with increasing survival and all, some diseases are definitely going to increase. And if we are going to protect them, protect the population, or increase the lifespan or quality of lifespan, some vaccination, preventive vaccinations are important. And we have got a very good success story actually of adult vaccination. One success story which comes to my mind is related to Japanese encephalitis vaccination. When we started facing the AES burden, initially it was a disease considered to be of under 15 years of age, where most of the children were dying. Gradually, in the endemic states, it was noted that adult people were getting more and more AES cases. And eventually, when adult vaccination started, the AES morbidity and mortality came down. So this is one success story. Even smallpox eradication can be considered an adult vaccination success story. And especially the COVID, that is another challenge we faced very successfully. So adult vaccination per se, not only limited to these few infectious disease, and some evidences are showing that probably influenza vaccine or flu vaccine has got very important role in reducing ICU admission or hospital admission or mortality, even in coronary artery disease patients or stroke patients. So there are ample evidence, not only the impact of vaccination transcends beyond the boundary of infectious disease and also helps in non-communicable disease. I think I think sir and others are there. I think experts are there. They can also, because sir is there from gynecology, so HPV vaccine is there. There are other diseases. So you must be telling, because hepatitis B related to cirrhosis and malignancy. I think Dr. Tiwari will be highlighting on these issues. Sorry. Yeah. I cannot hear you, Ribu.
Okay, so thank you, Dr. Promit Ghosh, for the introduction and setting the ball rolling. Now I would like to request that Professor Harivansh Chopra, that he has been involved in vaccination in children for a very long amount of time. So how can we integrate this adult vaccination program into the existing immunization program in India? So your opinions, please, sir.
Thank you, Rivu. It's a pleasure to be here in this particular panel discussion. And having an experience of more than 3 decades on immunization, I established immunization clinic at my urban health center, and I could achieve the more than 95% coverage as far as my target population was concerned successively over the years. So we know that yes, immunization is a very, rather I should use the word vaccination, because majority of time vaccination and immunization are used synonymously, but they are not synonyms. One has to understand that when we are talking of vaccination, we are talking of only giving or administering a particular vaccine, and immunization is the result of that process. So these are 2 different things. So we should call that vaccination clinics, right? Because everybody who is vaccinated is not going to be immunized, and that these are the basic facts which are to be kept in mind, because every vaccine has got its own efficacy. Now, yes, it is important. Now we have to, before we venture into this exercise of establishing adult immunization clinics, we have to understand that, like you asked, where is the evidence? You see, the evidence can be collected only when we have shifted from manual to EHR. And once we are shifted to EHR, and already there is one program, which is what is known as IDSP, you can gather data from the IDSP itself, which will be given you enough proof of the burden of the diseases which can be prevented by vaccination. Number 2 point is that yes, there are a number of vaccines which are to be given to the vulnerable population, and we have vulnerable population in our country to a very large extent. Like elderly, if you're talking about, we have 9% elderly, which in sheer numbers cross more than 10 crores. So that is one aspect. Then similarly, if you are going to talk about the diabetic people, again 7%. If it is the prevalence of diabetes in our country, so again there are 10 crore diabetics who are vulnerable to get the various diseases. Now talking about that, yes, if we can have that kind of a data, and this can be launched, the adult immunization can be launched by 2 ways only. Either the government of India start this particular program, and before the government of India start thinking to launch this particular program, there are certain prerequisites which are to be fulfilled. Number 1, there has to be a policy. The politicians are to be sensitized, and they must understand the need. Only then it can be integrated at those places. The second thing is, when we are talking of adult immunization, we have to understand that if you are going to incorporate new vaccines, of course, the capacity to store the vaccine has been there or has developed because of the COVID pandemic. So that can be done. That is already there, and that can be utilized because routine immunization is going on, and we are also going on with the COVID vaccination. So that aspect is to be kept in mind, and the cold storage and the effective vaccine management has to be looked into. Then the third aspect, important aspect, is the timing, because adults majority of time, they are working somewhere. So you can't have those morning timing for the immunization sessions, which we are doing it for the children. You need to have a special timing for adults, because nobody is going to miss the work and then to come and take immunization. So you need to think about all those strategies. The other aspect is, like the private sector is already doing it, The vulnerable people are already taking the vaccines. Like I have taken the influenza vaccine. I take influenza vaccine every year. I have taken the pneumococcal vaccine. So it's up to the people to take the vaccine. But then it is our job also. And I always say every doctor must do immunization. And when we say every doctor must do immunization, why? Because even if we are running the immunization program for 1985 universal immunization program, we have not been able to reach to the 100% of the population. So you'll have to understand that to cover that population, and similarly, if you are going to add the adult population, it's a huge population, and we have been successful to say by today how much something more than 100 crores, 183 crores doses of COVID vaccine has been given in last 1 year. But that's a exercise which is totally based on the government commitment. The first step, if you want to involve or if you want to start adult immunization, is then you have to get the granular data that these are the people who are dying, these are the vulnerable people who are dying due to pneumococcal disease, these are the vulnerable people, these are the number of the people who are dying because of the hepatitis B, these are the vulnerable people who are dying because of the cancer cervix, these are the vulnerable people who are dying because of the influenza. And if you can compile that particular data, whether with taking the help of IDSP or some other mechanism or EHR, which is going to come up in our country, which is coming up in a number of states. So that way, that will be a very good evidence to convince the government that yes, there is a need for adult immunization. And once the government is convinced and the politician, they do agree to take action, because ultimately everything boils down to economics, the budgetary provisions and everything. So you'll have to understand, if the initiative comes from the government, then it is going to be a good success, and we'll be able to prevent a lot of mortality in the vulnerable population. Of course, it can be integrated with the immunization clinics which are running right now for the children. But yes, the time factor has to be taken into account. These are my views on adult immunization. Right.
Thank you, sir. So now we understand that we are going from a technical side to an operational side. So there was a good discussion on the technical side by Dr. Reena Ghosh and then Dr. Pumit Ghosh. And you rightly mentioned some problems in the operational side also. And this is true that with the huge success of COVID vaccination in India, maybe if the government has got the right ideas in their mind, they can do that. Okay. So with this background, I am now going to our
Dr. Ibu Vasu.
Yes, yes,
Dr.
Ibu
Vasu.
Yes.
I want to discuss one,
Yes, yes.
rather it's a statement I like to discuss with Dr.
Yes, yes.
Chopra. Dr.
Yes.
Chopra is absolutely
Please.
right in narrating that its government has to take some initiative. But before that, I like to mean that so far adult immunization is concerned, it is so neglected, even we doctors are not properly vaccinated. So if we are not convinced about the importance of adult immunization, so how can we make our medical association, so many associations from physicians and from surgeons and from your community medicines and so many, we are not being able to convince government, because we are, I think, not even as of today, not that much convinced so far the importance of adult immunization is concerned. So we have to immunize ourselves. We have to be ourselves convinced first, then we can convince others too. So we are really far away from the goal of adult immunization. Please proceed, Dr. Deepak.
Dr. Harivansh Chopra has raised his hand. So, sir, please, any opinions on this? Yes.
Yeah. I just wanted to say, when I was talking about, I said that example to you, that I take influenza vaccine every year. My family members who are there above the age of 60 years, they are taking, my friends are taking, and I have taken the pneumococcal vaccine. So everybody has to increase the awareness that is there. Even if the awareness is there, the need is there, the government is not sensitized. I can share my experiences. I worked with the government in the Urban Health Mission in 2009. The Urban Health Mission document was prepared. We did the detailed documentation for each and everything, starting from the infrastructure to the drug requirement, found out the prevalence of various diseases and for how much population it is going to cover, 50,000 population, what kind of drugs will be available. And I'm sharing with you here right now, we thought it will be a very easy process, because there is a IPHS for the sub center and the primary health center, and we said we just have to apply a multiplication factor, but that is not true. You see, you have to prepare a document which should be based on the real evidence, and what I said is important. Even if we we keep on immunizing ourselves, we keep on awareing people. Government is not going to listen. Government is going to listen only when you are able to produce the data in a granular form and sensitize them the need, right? If you are going to have the World Congress on Immunization in April, it is my suggestion, you involve the health minister of your state or health minister of the country, call him there. Once he is sensitized about the need, then things will move on. Why? Because we prepared the document in 2009 and it was shelved by the then health minister, stating his own opinion that there are no doctors available. And all of you know that the Mohalla clinic later on was opened in Delhi and how successful they are and how what changes they have done. That is the impact on the election of the government also. So you have to understand, if you are able to convince them that this is going to benefit people and ultimately it will increase your vote bank, ultimately it will be converted into the votes, so then definitely they are going to do that. So that is my point.
So thank you for the saying, coming to the point of like politicalization of the adult immunization program. So I think Dr. Promit Ghosh has also raised his hands. So please, can you?
Just little remark. I completely agree with Dr. Hari Chopra what he said. And I was going through an AIMS Jodhpur probably started an adult immunization clinic. And their experience shows that over 1 year, they vaccinated around 1,400 adult people. And majority is post-exposure, either tetanus or anti-rabies. If this is going to, I mean, if doctors, wherever you are, we talk about missed opportunities for children. For adults also, we should start talking about missed opportunities. Whoever is a clinician in geriatric clinic or in any clinic, they should start talking about missed opportunity of adult vaccination.
Okay, so that's a very good idea, because Dr. Bharadwaj will be there in the main conference sharing his experiences of AIMS Jodhpur also. So coming to the missed opportunities, now I will directly go over to Dr. Dibyendu Banerjee, please. Okay, so he's a consulting practicing gynecologist in Kolkata. And like whenever we are talking about adults and we are talking about children, we often tend to forget about the age group in between, the adolescents. Okay, so there are some vaccines which is required for the adolescents too. So like the HPV vaccines, which there is a huge demand. Can you tell us about something about the like requirement of HPV vaccine, the evidence? Thank you. Please,
yeah, basically, good evening. Basically, the thing that we should remember is the burden of the disease of cervical cancer in our country. Annually, we get around 120,000 addition new cases of cervical cancer. 65,000 women die of cervical cancer every year. And till date, we are not convinced about vaccinating the adolescent girls against cervical cancer. So we know that we've got wonderful vaccines. We've got a bivalent vaccine. We've got a quadrivalent vaccine. We've got now a nonavalent vaccine, which covers 9 viral types. So ideally, it should be given, prescribed by pediatricians from the age group of 9. If the girl misses the bus, then it is the prerogative, I would say the prerogative of the gynecologist to suggest that it is high time that you got vaccinated against HPV. But we see many women who have missed it. The first time they are hearing about it is when they come to a doctor, a good contact with a doctor during childbirth. And that is the time when they talk about child immunization. And so we should talk about postpartum immunization against cervical cancer, which is once again very effective. Once the patient is discharged, the first day you give them the first shot, advise them the second shot after 2 months and the third shot after 6 months. Recently, the government has given approval of vaccination against for adolescent boys for prevention of penile cancer and anorectal warts. So that the nonavalent vaccine has been approved for use in boys in the age group of 9 to 26. This is one step forward. But one thing that we should remember, that the cost is prohibitive. So it cannot be a universal immunization scheme until and unless the government, as doctor said, the government comes forward and gives some subsidy. It is not possible for a the people, the general people of our country which is, I would say, it's still developing, where the economy is still not flourishing, it's very difficult to manage around 3,000 rupees for a vaccine and 3 vaccines during the lifetime. That is very difficult. Another thing, there has been a gross change in during pregnancy. If I can cover about pregnancy. In pregnancy, previously we never used to vaccinate against influenza virus. Now we are vaccinating as a routine practice. After the first trimester, we give them a shot of flu vaccine. Now we are giving them a shot of TDP, that is Tdap, that is tetanus, diphtheria, and pertussis vaccine at 28 to 36 weeks. This gives them protection. These are things which are evolving, changing, and these changes, I believe, are for the better, but it has to be implemented by all gynecologists. I'm really sad to say that it is not a universal implementation program. So the people are not doing it. So until and unless we doctors, we are educated enough, or we are convinced enough to realize that times are changing and our practicing principles should change, we will not have a better tomorrow. That's it.
So that's an excellent closing statement, sir. And this opinion is coming up all the time, that if we are not conscious about taking the vaccine, then we cannot tell the patients to take the vaccine, and about the economics of the vaccine. So the costs are really prohibitive for many of the vaccines. So with this in background, I will like to ask our chairperson sir himself, that he is a specialist from medicine, Dr. Kormokar, Professor Kormokar, and there are some vaccines which may be given during routine time, and there are some vaccines which may be given in special situations. So, sir, can you elucidate on these special situations in which some vaccines are mandated in adults?
Yeah, thank you, Dr. Yuvasu, for a very pertinent question. So what I want to mean that whenever we are thinking about the adult immunizations, what is happening if special situations, like if you go for splenectomy, suppose a person has been suffering from thalassemia, hemolytic disorders, and patient is having huge spleen, and his or her blood transfusion she is needing or he is needing in a great frequency. So in that, to curtail down the number of blood transfusion, you may have to go for so in that case, in that special situation, we have to think about some routine vaccinations like pneumococcal influenza B, as well as other pneumococcal, something like that, those who are having capsules. Dr. Poddar is probably talking. Dr. Poddar, would you please mute now yourself? I will go to you just immediately after this. So in some situations are there, like where splenectomy is needed. I mean, the planned splenectomy is needed. So apart from that, you know that we have to go for some booster dose of tetanus, as well as herpes zoster, something like that in the adult immunization. So otherwise, we are really lacking so far immunizations of the adult is concerned. So we have to plan it, and accordingly, we have to maintain adult immunizations. We have to boost adult immunizations among the general people. Without awareness, we cannot reach success.
Thank you, sir. For mentioning some situations.
Our Dr. Shumit Poddar,
yes,
sir, is also here. Please call up.
Right, so Professor Poddar had some technical difficulties, but thank God he has been able to join us.
It's all right. Yes,
okay,
yes.
Sir.
I can hear.
Yes. And sir is an expert in rabies. I am introducing him in just one line. He's an expert in rabies. He has been in several important positions in APCRI. And if you see his clinic, which he runs for rabies patients, and we all look up to him whenever we talk about rabies. So, like when talking about adult vaccination, we are all thinking of routine immunization only, right? But other than routine immunization, there can be immunizations in some special situations, like in some emergency cases, like rabies and tetanus, etc. So, sir, can you please tell us about the status of rabies vaccination in the government sector and the private sector now, and what do you think about that?
Now, one thing, we are dealing with such a disease that is 100% fatal disease. The main thing, because if we go through the previous history, we'll see that at least we are losing 20,000 patients every year. But the most important part is that these are the vaccine preventable disease. So coming to it, now the need for the adult immunization, particularly vaccination program, there are two things are very important. One is the pre-exposure prophylaxis, another is the post-exposure prophylaxis. Although the children are also being a victim, moreover, the adult, the number of the patient death, if we search out, we try to find out the number of the patient death, their age, also many adult patients are dying every year. And now, in the last 2017, we have gone through it. Now the figure has come down to near about, it is 12,000 or 10,000, something like that. Now, the APCRI is working, no doubt about it. The government should come out very methodically, because each and every patient needs the proper pre-exposure prophylactic doses. If we can give this one, at least we'll be able to, we have a target of a rabies-free country by 2030. At least we'll be able to cut down the figures. And definitely one day will come by 2030. It is our WHO target, and the Indian scenario, NCDC, is having the same target along with our APCRI, our association, that will come down to definitely will be able ultimately control of rabies throughout the India. My take-home message to each and everyone: don't ignore this fatal disease, because it is a vaccine preventable disease. At least if there is any kind of dog bite, it should be dealt with separately, meticulously, so that we'll definitely will be able to control rabies. Another important part is the usage of rabies immunoglobulin along with the vaccination is very much important. So there should be some strict, rigid rule that the primary and pre-exposure vaccination should be needed. And if we get, the main advantage is the incoming of the post-exposure time, the patient will get already only 2 doses of vaccine. So the role of adult immunization, particularly in the field of rabies, has got immense importance. So I think definitely we'll be able to control rabies by administering the proper dose of vaccine in each and every patient throughout the country.
Right, sir. So rabies is a 100% fatal disease, and vaccination is probably the only way out. Coming to rabies, we can think of another organ which is equally important to us for clearing all our dirts, the liver. And we know a host of viruses can infect the liver. And for most of these viruses, we have vaccination, which people often miss. So, Dr. Indrajit Tiwari, with your huge experience of vaccines for liver, can you please elicit us on what you see in your clinical practice and what you see as the way forward?
Sure. Thank you, Dr. Rivivasu, for giving me the chance, for the organizer giving me the chance. Really, I am privileged and honored to put my thought process in this August forum. Basically, since I am working in a specialized critical care, that is gastrocritical care, I usually come across the patient with liver failure, acute liver failure, chronic liver failure, or acute and chronic liver failure. And when I saw these patients are suffering from hepatitis A-related chronic liver disease, or this patient is having fulminant liver failure due to hepatitis A, we have a great shock. Immediately, I asked myself why we are not encouraging people for this hepatitis vaccination. Because fulminant liver failure due to hepatitis A, in last 10 years, at least we have do 5 to 6 transplant in acute liver failure related to hepatitis A, which was a totally preventable disease. So since being the immunization schedule is very simple, For hepatitis B, you have to take 3 doses, and hepatitis A, you have to 2 doses at an interval of 6 to 12 months. So that sort of simplicity is there. In spite of that, we are unable to put forward the thing in the public domain. So when I am leading the adult immunization program in Apollo, I was in lead. What I did in my department, in my hospital, I tried to make the awareness more frequently. So we put a different OPD clinic, like adult vaccination clinic in gastro ward. When people coming for the liver clinic, by side they are seeing a vaccination clinic, adult vaccination clinic. Similarly, we posted a similar counselor in a room in the gynae department and a medicine department. So we have 4 or 5 clinics running in different departments with a good counselor, which can who can counsel them and make them aware what is the importance of this vaccination, hepatotropic viruses. Since hepatitis B, whatever you do, you can control the disease, but ultimately it is leading into a good amount of chronic liver disease. And hepatitis A, for the clinical part, I would like to say you 2 or 3 things, important things. Regarding the titer, in the subset of people who are listed for liver transplantation or kidney transplantation, organ transplant, solid organ transplantation, usually we do the titer level even you have the, because the response rate in this dialysis, ongoing dialysis patient or chronic liver disease patient, the seroconversion is less. Suppose in normal population, it is 95 to 97% with 3 doses or 2 doses. In this special subgroup, it is only up to 66%. So in that case, you have to give a 4th dose or booster dose, or you have to repeat the whole vaccination schedule to prevent the disease. Second important thing I would like to highlight, what we have observed in last 5 to 6 years, last decade, with the development of this MRI PDF, fibroscan, and other scan, which can detect the fatty liver NAS, particularly in diabetic groups. They are most vulnerable to develop chronic liver disease. And very rapidly it is increasing NAS, non-alcoholic steatohepatitis leading, like in diabetic leading to the chronic liver disease. This subgroup of patients should be vaccinated at high target. So what we are planning, we plan to put a counselor or vaccination coordinator at endocrine department also. Those who are diabetic or who are being pre-renal failure or in CKD, this should be vaccinated. So I think for the medical perspective, we have to keep in mind the vaccination schedule, the titer level, and the risk group. And for the public domain, I think we need to aware. If you are making family to aware, that can be a great thing. And if the doctors fraternity take the challenge, individual department take the challenge, then only it can happen. Definitely with the help of the government support in mass. Yeah, Dr. Ribu.
So thank you, sir. And coming to your point that how can we make the people aware? You have experiment with the counselors in the OPDs. So I am coming directly to one of the questions asked by one of our spectators. This question is for Dr. Harivansh Chopra with his huge experience in like operational aspects of vaccination. The ones related to healthcare knows or have knowledge about the requirements of adult vaccination, but even in the allied classes of society, they try to avoid this vaccination. So what can be done to promote immunization among all these commoners? Sir, please.
Okay, thank you, Rivu, for asking this particular question. You must understand that I always say that yes, medical science has made a lot of advances, and vaccination has gone a tremendous change. And from 6 vaccines now, even in the immunization program, we are having more than 10 vaccines. And again, the role of the government is of great importance. Now, coming back to the question that why even the elite class does not take the vaccine, there could be 2 reasons. You must understand. I can share my experiences because I started immunization in 1985 in my field practice area, and I know how I build over it. You must understand that whenever we talk of patient for treatment or we talk of giving vaccination, there is one factor which is very, very common in India, that the practice is still till date today is faith-based. The patient has complete faith on the treating doctor. And that is one way to enhance. If the treating doctor tells the patient that this is essential and this is for the betterment or for your life, this will prevent the occurrence of number of diseases if you follow the advice. There is no reason that the patient will not follow that advice. You have to understand, if you are treating somebody and then you are advising the relatives of that particular patient who are not taken treatment from you, it will be a difficult phenomenon. But if you are treating a patient and you are telling him or his family member, definitely they are going to listen to you. And this was the only reason. I'm not talking of individual. If I'm saying my model was appreciated by the state government, by the local government, by the local authorities, and now they are collaborating with us, that they are providing everything to our center. We don't have to procure anything. We just have to give vaccination. Why? Because we have developed faith over a huge community. And you must understand that you are the treating doctor. So you have to club these two things together. And like what doctor was saying, that yes, when they put the counselors, why they are putting the counselors? Because they don't have time to explain. But the counselors, if the doctor says the counselor is going to talk to you, again, it is taken as advice of the doctor. The counselor worked on the advice of the doctor, and the patient is going to listen. The point number 2, which is again important, as far as hepatitis B and A, I wanted to come in at that particular point of time. Hepatitis B is there in the universal immunization program, but hepatitis A is not there. And then we'll have to understand that we have to give the vaccine prior to the exposure of that particular disease. So again, yes, we need more data. If we can produce more evidences and data, then hepatitis A can be included in the immunization program. And if it is given right in the childhood, then a lot of mortality due to hepatitis A can be prevented. So this is my take on that.
So, sir rightly talked about vaccine hesitancy, and we know how a problem it is in the under 5. And there is a lot of hesitancy even at this stage in the adult population. We know that. Coming to vaccine hesitancy, I am coming to a question by Dr. Shati Ghonge, who has asked us that what is about the AFI reporting of COVID vaccination? Why is it not in public domain? So, Dr. Ghonge, maybe this is not the question for this forum, but talking about AFI, I'm coming directly to Dr. Promit Ghosh, who has worked with AFI for, I think, 5 years in West Bengal, to tell how the AFI can be, like, what is the potential side effects of these adult vaccines, how the AFI mechanism can be built for adult vaccines also. Dr. Promit Ghosh, please.
Yeah, I think whoever has worked with vaccination has faced this challenge of AFI. Reena madam is there. I think Dr. Chopra is also there. Whoever is working. See, in West Bengal, I have worked with AFI for maybe last 10 years or more. And the experience has always been that only in children we get the reports. Though theoretically, AFI should be reported from all the vaccination, whether it is UIP vaccine or otherwise, whether it is rabies vaccine, whether it is yellow fever and all, but we rarely get the reports. The main problem of AFI reporting is that AFI mostly is not reported to the site where the vaccine is given, because the person who is getting the vaccine, who is facing the problem, usually goes to some other clinician who has not vaccinated the person and who treats the person but never reports it. But the reporting system is available. I mean, we have shared all the links and all multiple times, especially after the COVID, but it rarely gets reported due to some or other issues. So one challenge, I mean, one approach can be, we can approach through Indian Medical Association or other associations to sensitize the persons or doctors or physicians who and can give some number or WhatsApp, so that mostly why I think whenever I was spoken to my colleagues or friends that why don't you report these cases? Their concern is if we report, people will ask us so many questions and we need to keep all the documents. So nobody is interested to go through all this documentation. So that is one challenge. And secondly, they also are afraid of any legal implication, because in India, it is not very clear that AFI reporting somehow, whether it has got legal implication or not. So it is not very clear to those who are reporting, those who are facing the problem, and especially about the treatment cost and all. So these are few challenges. However, I should say that in West Bengal, in case of childhood vaccination, is one of the leading states which reports in reporting and verification of AEFI. And that's very good. I mean, we should be proud of that. In West Bengal, we report that much. But in case of adult vaccination, definitely some adults are getting vaccines, and some AEFIs are definitely happening. But at state level, no report is coming. Even in COVID, when we started this, initial reports were there. Gradually, number of reports started to numbers came down drastically after a few months, because gradually people got the thought, started thinking that these are very common. So most of the common AFIs were not reported at all, and fear and apprehension definitely were there. So these are the few points. I think if we want to really strengthen the AFI network, we should have a linkage with the, because we have got a platform where pharmacovigilance is also working, AFI is also working. So some common platform which is already available, that should be promoted, and mostly people do not know that these platforms are there, where with a click of a phone or one phone number, we can just report it, and after reporting, it is actually state's responsibility, AFI committee's responsibility to investigate that. So doctor or whoever is clinician, they should be sensitized, and they should be requested that just drop the mail or drop an information that we have found an AFI, then somebody will contact you and get the information. So eventually pharmacovigilance and AFI will merge, but in both the ways, we are not getting side effects information of drugs, neither AFIs. So somewhere in these forums should be, I don't know about experience from other states, mostly AFI reporting, serious and severe AFIs are reported, minors are rarely reported. And that is our experience pan India mostly. We have, I have investigated the AFI in other states also. Some deaths were there, but similarly only serious and severe AFIs are reported. Minor AFIs are mostly ignored, and that is why we're lacking. If we can convince people that vaccines can lead to AFI, but now more than 95% of AFIs are minor, then it can boost confidence. Self-limiting minor AFIs. Otherwise, this apprehension of AFI will definitely be a deterrent for adult vaccination. I don't know how many of your colleagues have taken the precautionary dose of COVID. I'm not yet sure. I'm asking my friends and all. Still, there is some hesitancy about third dose or other doses. So these are issues that should be dealt with, and everybody is apprehensive. And another is, I think that credibility of our data. What Sir was telling, that EHR and all this, and we ourselves are not always very have that confidence in whatever data we generate. So that is another problem, I think. That's
Okay.
all, I think.
Okay, so that's a very nice discussion on AFI. So coming to AFI and the hesitancy, I would like to get the next question to Dr. Bendu Banerjee. Sir, Dr. Dipanshu Saxena has asked us that cervical cancer is one of the leading causes of death in India, and like adolescence as a malignancy, and like why there is still limited planning in production and cost bearing of HPV vaccines in the government sector. So most of the like people of poor age brackets are not getting the vaccines. So any light on this, sir?
Sadly, as in many areas, the government is not proactive on this issue. I believe, yeah, there are a lot of issues regarding the volume of money which has got to be spent on this. I believe the government is convinced. We've got medical personnel both in the center and the state governments, and they can go a long way in negotiating the prices or giving a subsidy. At least if you subsidize cervical cancer vaccine, we would do the society a world of good. Moreover, the main thing is the awareness regarding this silent killer. That awareness is missing in our country about cervical cancer. We are so very concerned about COVID because it's come as a sudden tsunami. But these silent cancers, diabetes, cervical cancer, there should be a lot of awareness about it. Once the awareness is there, the demand comes from the general public that we want to get immunized. And then there is a reverse pressure on the government agencies.
Absolutely, sir. And so the pressure has to be built from professional organizations like this only, with esteemed speakers and stalwarts like you, who shall be advocating to the government regarding building the pressure also. So there is another question by Dr. Snehashi Vishakpatnam, that what is the recommendation of hepatitis A vaccination in COVID context? So Dr. Indrajit Tiwari, please, if you can answer on that.
Yeah, the protocol is same, remains the same. There is nothing to change with the COVID control. It can be administered in either of the setting. So indication-wise, it is same. What Dr. Chopra is highlighting that it should be included in the program or not, this is based on the data. But in Indian context, since after a particular age of 10 to 12, most of the patient is getting IgG level. But what I am discussing about the high-risk group patient those on the organ list, like waiting for the liver or kidney or heart transplantation, solid organ transplantation, diabetic patient, elderly patient. In that subgroup of patient, if you do the screening or the IgG level and you immunize, it is very, very, very beneficial, I think, for that subgroup of patient. And you can give it on simultaneously on in the same period, nothing contraindication with the COVID vaccination schedule.
Okay, so the schedule remains the same. And Dr. Krishna Bhattacharya has asked about like whether the people should be taking influenza vaccinations each year. So this brings to the important question of a geriatric vaccination, because we prescribe vaccines to the geriatric population now as a part of the adult population. And so they often come to the chamber and ask us that, shall we take the same vaccine over and over? And besides, he has also asked about the recommended schedule of pneumococcal vaccination. So I'm putting this question directly to our chairperson, Professor Kormokar. If you can take on this question, please. Professor Kormokar. Okay, so maybe there is some connection issues with Dr. Kormokar. So we shall take this question later also. So our experts will not be able to answer all the questions because the lack of time. Just one or two more questions. So a question for Dr. Shumit Poddar, like, can a person being treated already with an emergency vaccination be given a regular vaccination? So this is the question for Dr. Shumit Poddar, or any other person can also take this question, that a person has got emergency vaccination, shall he be continued with the regular vaccination schedule?
There is no contraindication. Any patient at any time, even the patient if received COVID vaccination, he also be allowed to take the anti-rabies vaccination. Similarly, if the patient has received any other vaccination, there is no bar. And anti-rabies vaccine, as because considering rabies is 100% fatal disease, it is never gave second chance to treat. So he must be given the full course of anti-rabies vaccination. That is the main thing. And we are proceeding in such a way that you will be happy to know that this time already our rabies has been included in our neglected zoonosis disease. So government is having that plan that to set up more and much more centers, at least to provide the anti-rabies vaccination. And one thing we must be cautious today, as because we are dealing with the adult vaccination, each and every patient should get only 3 doses of pre-exposure vaccination. The main advantage is when he will report with post-exposure prophylaxis, then he will receive only 2 doses of vaccination. throughout the country, throughout the all sectors. So in this adult vaccination, it is very important thing because this thing is a life-saving measure. So we'll have to deal with this vaccination program.
Thank you, sir, for enlightening us.
Welcome.
And so, with the flurry of questions which I am seeing in the question answer box and in the chat, it is impossible to answer all the questions. So keep your enthusiasm up because this is only the curtain raiser, and we shall be having the mega event coming up in the next month. We shall be trying to have speakers from all over the world in that event. So please keep up your enthusiasm, and we shall be announcing the mega event soon. So thank you all the experts, and I am for the time because you're all very busy persons and you have been able to give your time here. So I now directly hand over the mic to Dr. Saurabh Kole to continue with the rest of the session. Dr. Kole, please.
So till now, we have listened about the various aspects of adult immunization, the current scenarios, and the future road ahead. However, the process of development of a vaccine, making it ready for vaccination, is itself a difficult and prolonged journey, which is usually not focused upon. Many people are working behind whom we are not being able to see, but they are working day and night for doing this invention. I invite our next speaker, Dr. Prasad Kulkarni, to throw some light on this less discussed topic of vaccine development and enlighten us on this aspect. He is from the Serum Institute. He is the director of the institute. Dr. Prasad Kulkarni, please.
Thank you, Doctor.
And I just want to say a few words about Dr. Prasad Kulkarni. He's a clinical pharmacologist with several years experience in new drug development, clinical research, pharmacology, and pharmacovigilance, regulatory practices in medical advice. He works at the Serum Institute of India. Here, he has been involved in the successful clinical development of several new vaccines and therapeutic large molecules. He has more than 70 publications in journals like the New England Journal of Medicine, Lancet, Infectious Diseases, Clinical Infectious Diseases, Vaccine, etc. He has been a faculty to many national and international conferences. He has been a faculty to the Indian vaccinology course at CMC Vellore for last 12 years. Dr. Prasad Kulkarni, please.
Thank you, Dr. Kole, and good evening, everybody. I think we have 10 to 15 minutes time, so I will try to be very brief on what goes on exactly when a new vaccine is developed. So to start with, basically you have to identify the problem, the disease in question, which you want to address, the epidemiological burden, the severity of the disease, and all these aspects are taken into consideration to decide whether a vaccine or disease needs to be prevented and whether it is worth making a vaccine, to develop a vaccine, because developing a vaccine is a very long, time consuming, very rigorous, as well as a very expensive exercise. And therefore, if it is worth, and if the policymakers are interested in taking the vaccine, because unless the vaccine is going to be taken up in the universal immunization programs of the countries, there is no point in making a vaccine. And obviously, the vaccine can come in the program only if it's a big public health problem. So WHO usually publishes a list of high priority vaccines that they think that should be part of EPI schedules in various countries, and so that list also becomes a good guideline. Once the product is identified, then the various technologies are scouted to see which technology can be the right one for making the new vaccine for a new indication. Now, I don't know whether you are aware of the various types of vaccines, but some of you may be aware. For example, the traditional vaccines include something called a live attenuated vaccine, where the live viruses or bacteria are attenuated, so they lose their pathogenicity, but at the same time retain their immunogenicity. Then there are inactivated or killed vaccines like pertussis vaccines or influenza vaccine, where those viruses or bacteria are killed by various chemical or heat methods, but they retain their immunogenic properties. Sometimes some infections, toxins are responsible for the pathogenesis of the disease, like diphtheria or tetanus. There you can change the toxin, detoxify it and make it a toxide. Then that's why you have diphtheria toxide or tetanus toxide. Then you have something called as a subunit vaccines, where you just take a piece of a virus which is really responsible for pathogenesis of that infection. For example, hepatitis B, where we know that the surface antigen is really very important. So you just use the hepatitis SBSAG surface antigen, which is manufactured by recombinant technology using some kind of yeast, so that the yeast is, genetically modified so that it can start making HBsAg, recombinant HBsAg, and that becomes your vaccine. Inactivated vaccine, I told you, polio vaccine, for example, IPV is an inactivated vaccine. In terms of live vaccines, you have MMR, measles, mumps, rubella, you have varicella vaccine, zoster vaccine. You also have BCG vaccine, which is live attenuated against Mycobacterium bovis. So these are the various types, and there are new types like VLP, virus-like particles. So your HPV vaccines are based on VLPs. Then now with the COVID, as you know, that new platforms have come in picture, like mRNA vaccines. We know Pfizer, Moderna, both vaccines were based on mRNA, where the mRNA was injected, and it was our body cells which express the spike protein of the SARS-CoV-2 virus, and then body's immune system started making antibodies against the spike protein. So mRNA vaccines, obviously, this was the first time they were used, though they were in the making for a long time. DNA vaccine has also been the first time in the world made by an Indian company, and we'll get to see their results, their experience. mRNA, of course, have been extensively used for COVID, and looks like they are not having any major problems. At the same time, they are working fine. Then viral vector-based vaccines like Covishield, for example, which is based on the chimpanzee adenovirus, which is a replication deficient virus. So this vector or a carrier, it has the genetic material for the spike protein of the SARS-CoV-2 virus. And once it is injected into the body, then our cells, they basically express this spike protein, again, same thing like mRNA, and then start making antibodies against the spike. So this is again, though this viral vector-based platform was in development for last several years, and there were already studies done for other indications like for chikungunya or for malaria or for Ebola. So there was already human experience on that platform, and obviously the vaccine could be made, and Covishield was one of the most commonly used vaccines in the world. And it has been found to work absolutely fine, give excellent protection, and also was quite safe. So these are the different types of the vaccines. So you basically select the right platform for making a new vaccine. And once you identify that, then you can develop it de novo at your institute, or sometimes the technologies are available either with some other company or with some university, some other groups, academic groups who have been working on those particular candidates for a long time. You start working on these technologies. There is, of course, a very elaborate process behind making the right formulation, whether it should be a lyophilized vaccine, a liquid vaccine, does it require any adjuvant, does it require any stabilizer, any other excipients to make it stable, because you don't want a highly unstable vaccine. Like, for example, Pfizer COVID vaccine was a very unstable vaccine. That's why it required -70-degree storage, which is operationally, it can be extremely challenging, especially in the developing countries like India. So you want a very stable formulation. So all those thoughts go into behind the development. And after taking into account all those factors, then the right formulation is prepared. And then this, obviously, it is not one formulation. You have several formulations where you have different combination combinations because you don't know the dose. You don't know anything about the vaccine. So you make several such formulations, and then you test them in animals. You have to choose the right species of the animals which can respond to the antigen, because if it is not the right species, then you won't see the immune response, right? And then obviously you won't be able to make the selection of the right formulation. So you go for the right species. The animal model is usually established for those kind of infections, and then doing several such formulation testing in the animals, then you get to know which formulation gives you the optimum immune response, and at the same time, it is not it is not causing any harm. And so these studies give an opportunity to find the right formulation, right route, because again, you don't know whether it is intramuscular, subcutaneous, intradermal, or what. The route, the schedule, how many doses would be probably required. After getting all this information, then you freeze your formulation. Then you have a fair idea about the schedule and the number of doses and the route of administration and all that. Once you freeze your formulation, then you get into again a next step of animal studies, preclinical studies again, and these are called as animal toxicity studies, where you create a worse kind of scenario in these animals, so as to find out if the vaccines have any toxic effects. Now, these steps are not really typical only for vaccines. These hold true for all new medicines, correct? And the same applies to different chemical drugs, small molecules, or large protein-based biologics. Basically, worst kind of situation is created either with single dose, so that you know that if at all an overdose is given to animals, whether it causes any toxic effects. And then also repeated dose studies, depending on the kind of schedule you have in mind for human usage. Let's say you have a COVID vaccine in mind, which you think probably 2 doses will be required, then you are supposed to go beyond, at least 1 dose beyond that. So N+1 is generally the rule that is followed for vaccines. So if it is a 2-dose schedule, then you will give 3 doses of very high antigen quantity to the animals. Usually 1 or 2 species are required. Again, the relevant species which can mount an immune response, which can respond to the vaccine antigen. And then you follow these animals for a certain period of time. You check their biochemical, hematological, various parameters. You look at their clinical symptoms. You look at their food intake, water intake, and all the very elaborate studies these are. And then ultimately you sacrifice these animals and you do their gross pathology, look at various organs, their organ weights, gross pathology of the organs, histopathology of the organs, of all the major organs, to check whether the vaccine has caused any effect on any of the organs, right? You also have some kind of recovery group where you try to see whether the vaccine is causing any delayed toxic effects, right? So you create all this data, and then you see that okay, the vaccine has not caused any toxic effects, and neither in clinical symptoms or any biochemical or lab parameters, also on the organ pathology. Once you have all that confidence that yes, this vaccine, even at very, very high doses, is not causing any harm to the animals, then you know that you have the right combination of the vaccine, which is absolutely safe in animals. And then you go to the regulators to ask for a permission for something called as a phase 1 trial or first in man trial. Phase 1 trials are usually conducted in healthy people, absolutely healthy adult population of, let's say, 18 to 35 or 45 years, small number of people, 20 to 40 to 60. And then you usually have a control arm. So one group of people receive the new vaccine, one group receive either a placebo, or if there is another vaccine already available, then you take that vaccine as a control vaccine. And then you see whether the vaccine in absolutely healthy population, whether it is causing any harm or not, short-term as well as long-term harm. Even there, you have very strict entry criteria, inclusion exclusion criteria, and then you follow them not only for clinical picture, but again, same thing. There are various lab parameters, whether any of the biochemical, hemat parameters are getting affected, all sorts of lab parameters. Their ECG is done, chest X-ray, everything, and again, you collect all the data, and then if you find there is no problem at all, the vaccine is absolutely safe in healthy adults. When I say absolutely safe, it does not mean that the vaccine is completely free from adverse effects, adverse events. No vaccine or no medicine for that matter is there which does not cause any adverse reaction, right? We have to keep that in mind. Obviously, there will be some reactions like injection site pain or swelling. Sometimes there could be fever, headache, body ache, or something like that. But are they mild? Are they transient? If they resolve completely without any sequelae, so all these factors are taken into consideration. Because ultimately, you have to always look for the benefit to risk ratio. If the benefits are too high, let's say if a COVID vaccine is going to prevent a deadly infection like COVID, and at the same time it is causing few side effects like fever, headache, body ache, etc. Obviously, the balance is strongly in favor of the vaccine, right? So you have to be ready with some mild side effects. Once you have the preliminary data from phase 1 that yes, it is working fine in healthy adults, then you go to the phase 2 trials, which is usually your target population. For example, for COVID, obviously your adults were your target. But for pediatric vaccine, your target population could be young children, could be infants sometime, or sometimes it could be a geriatric vaccine. Then you get into that target population. And you also want to know what is again the right dose, because you know the dose from the animal studies, but you are not sure whether that dose is correct for the humans, right? Animals always do not tell you the truth. The species variation is very much there. So you do something called as dose ranging studies. Various formulations can be tried with or without adjuvant, one dose or two dose or three dose schedule, IM route or SC route, So again, these combinations can be tried, and it can be checked which formulation, which combination gives you the right kind of immune response. And then based on that data, you know that, okay, let's say my COVID vaccine is working fine. It is safe in the target population, and it requires 2 doses of the vaccine to give the perfect immune response at a very safe situation and intramuscular. And then you freeze that dose. And also, you know that, okay, let's say so much virus titer is required for giving the optimum immune response, or let's say so much antigen, 10 microgram antigen is required. Then you freeze that formulation and then get into the phase 3 trials, which are much larger in thousands of people. And again, you go into the target population. You have at least 6 months of safety follow-up. You give the 2 doses of schedule. Then you have, usually these trials are double-blind randomized controlled trials, so that there is no bias in your findings. So the investigators as well as the participants do not know what they are receiving. If it is a new vaccine, a brand new vaccine for which there is no control vaccine available, for example, let's say if you are going to make a RSV vaccine, obviously there is no currently available RSV vaccine, so you will naturally use a placebo. This placebo can be something like waterfall injection or normal saline, or it can be sometimes the same vaccine, just simply without the active ingredient, active antigen content. Or sometimes you could use another vaccine like a rabies vaccine or a tetanus vaccine, which obviously is not going to give protection from RSV. And then, but of course, if you have something like already there is a vaccine available, then you will use the available vaccine. As you say, let's say if today somebody has developed a COVID vaccine, obviously he will use available COVID vaccines as the control vaccine, because it is no longer ethically possible to use a placebo when you know that COVID vaccines are available and they should be used for the population. So you do these kind of double-blind trials, large trials. You follow these people for a long period. you actively collect the side effects for a certain period of days, let's say 7 days or 14 days, to see whether the vaccine is causing in the immediate period any reactions, local injection site reactions as well as systemic reactions. You collect all the data, and then of course there would be, and you have a list of predefined adverse reactions which you are expecting, from your phase 1 trial, phase 2 trial, you know what to expect. So those questions are specifically asked. Diaries are given to the patient. They are supposed to write down every day, measure their temperature, write down the temperature every day. If there are an injection site reaction, they are given measuring scales so that they can measure the swelling, measure the redness, whatever is there. So there is a very elaborate system, and then these diaries are collected by the investigators. They are collected into the database, and also sometimes you may look at this lab parameters. And then at baseline, you collect their samples to check for their antibody levels. Then at a certain time period, you again collect their samples to see whether the vaccines have made any difference in the antibody levels. Let's say, for example, for COVID vaccines, you would typically look for the anti-spike IgG antibodies, neutralizing antibodies, also anti-RBD antibodies. You may also want to look at the T-cell immune responses. So you will you collect their blood samples at baseline before the first dose, and then maybe 1 month after first dose, 1 month after second dose, and then you see, and the same thing will happen in the control arm, and then you compare pre-vaccination versus post-vaccination, also between the control and the study groups, to see whether the new vaccine is giving as much immune response as the available vaccine or not. This is when you know that the vaccine has certain immune response. Sometimes, if no immune response is known, then you have to do efficacy trials, clinical efficacy trials, which are again very large, 10,000, 20,000 people. For example, for our rotavirus vaccine, we did a trial in almost 8,000 young babies who got at 16, 14 weeks of age, either our rotavirus vaccine or a placebo, and then they were followed up for 2 years. And every time those babies got diarrhea, their stool samples were collected, and those stool samples were sent to CMC Vellore laboratory to check whether those diarrheas were caused by rotavirus, to look for the rotavirus antigen. And then those rotavirus cases were identified, and then at the end we had to unblind the data because everything was blinded, lab was blinded, and then we checked how many cases, rota cases, because there were of course thousands and thousands of diarrhea episodes in the trial in 8,000 babies, you can imagine, but not all of them were by rota. So the few that were caused by the rota, we looked at how many were in the vaccine group, how many were in the placebo group. Obviously, the placebo group had many more cases as compared to the vaccine group. And then on the basis of that, you calculate something called as the efficacy of the vaccine, correct? And that is what happened also with the COVID vaccines, where the efficacy was calculated on the basis of incidence of RT-PCR positive COVID cases in the vaccine group and in the placebo. And then based on all that data, efficacy as well as safety data that you generate, you go to the regulators again and you present the data. If they are satisfied with the data, if they feel that the benefits are much higher as compared to the risk, then they give you the marketing authorization or license. Of course, in COVID cases, you didn't get a marketing authorization. All of us got the emergency use authorization or EUA. And then the vaccine becomes available to all doctors like you. You can start using it. But even after they are available in the market, you have to keep on doing something called as pharmacovigilance, which means that you have to keep on looking for the adverse reactions or adverse events that happen in the real life. So this is called as the real world evidence. And so there is a meticulous follow-up that happens. And I heard some people talking about EFI. So EFI surveillance has to be in place, and those data also we have to then keep on collecting the data and prepare something called as PSURs or something called as periodic safety update reports. You have to submit them to the regulators for at least 4 or 5 years after the vaccine is licensed. Sometimes you may be required to do post-marketing safety studies to generate large safety data. and all that data goes to the regulators. And as long as the product is in the market, you have to keep monitoring the safety of those products, and also whether it is prone to any medication errors. For example, lifelike vaccines like measles vaccine, it has to be reconstituted, and once reconstituted, it has to be used within 6 hours. But there have been very few cases where the vaccines were reconstituted overnight and then used next day. And in such scenarios, there can be contamination by Staph aureus, right, which can lead to toxic shock syndrome, and the babies can, land up with serious problems. So medication errors, program errors, programmatic errors. So you have to keep watching for all of this, and you keep giving that data to the regulators. Also keep updating your product package leaflet, package insert, so that the doctors get the right kind of instructions on how to use those products. So this is in a nutshell about the vaccine development. I mean, it's a very long process, so it may take several days to explain, but this is what I think I gave you a brief overview. So that's all from my side. Thank you very much. And if you have any questions, please let me know.
So thanks, Dr. Kulkarni, for your excellent deliberation. As I have told you earlier, in our final program on 23rd and 24th, we need your support, and obviously we'll inform you beforehand, and so that we can organize the program in a better way.
Sure.
So thank you very much.
Thank you.
Okay. So we are now in our concluding session. As the saying goes, the morning shows the day. Similarly, the cartoon raising program showed how important and relevant the concept of adult immunization. In today's, we have seen the Indian scenario, as well as we have also seen the global scenario. The speakers highlighted the salient aspects of adult immunization, its global perspective, the need for adult immunization clinic, and the probable obstacles in achieving higher percentage of adult vaccination. As pointed out by today's speakers, we need national guideline, more sensitization of the target population, and increased awareness of the adult population regarding need for vaccination. With today's program, we begin our journey focused on Global Adult Immunization Summit, World Congress, scheduled on 23rd and 24th April. So, Indian Society for Adult Immunization welcomes you all to the World Congress of Adult Immunization. And this is the first time it is happening all over the world. And that's why we have named it as the first virtual World Congress on Adult Immunization. And you all know that the World Immunization Week is from the 24th to 30th of this month. So 30th of April. So on that World Immunization Week, we are organizing this program, the first virtual World Congress on 23rd and 24th April. I hope that the participants and the faculties who are here, they will support us in future also and be present in our final program. In the meantime, any suggestions or you please send us in our mail ID. And at the same time, whatever I am telling you, that whatever the questions on today, we will give it in the we will answer in the final conference, and there will be a separate session for that. And any suggestions from your part is highly accepted. With these few words, I am just concluding the session, and hope you have enjoyed the session, and you will definitely participate in future in our final program.
Please offer vote of thanks to each and everyone who has participated. Dr. Kole, please.
So you can also tell Dr. Kormakar.
Yeah. So on behalf of Carton as a program of World Immunization Program, I'm really thankful to all of you who have participated in this program. Am I audible?
Yes.
Yeah, I'm really thankful to all the participants who has really participated in this program and has made the program a grand success. Here, I like to highlight that our international speaker, Reda Sadki, and then followed by our national very important speaker, that is Rina Ghosh, along with panel discussions. Everything has been a very interactive session. So I'm really thankful to all the panelists as well as to all the speakers and chairpersons to be active part in this our curtain raising program. It's a very small, but it could be a very small, but it is our very sincere effort. If this program has been a little bit successful in increasing our awareness so far adult immunizations is concerned, then we will think our this small effort is absolutely successful. So with this little hope, we again invite you to come to our mega event that is on 23rd and 24th of April. And we have to make this program, there is a lot of work from Dr. Devdatta Halder, our assistant professor of Diamond Harbour Medical College, Dr. Arijit De, Dr. Arijit Sai, many other doctors. They are very junior but active doctors. They have played a very important role, and I am also thankful to to our digital platform provider. They have worked very meticulously to make the program success. That is Sonal Shah and Mr. Jignesh. I am thankful to all of you for your contributions to make this short program successful. And with these few words, I'm thankful to you all once again, and good night. See you again next month. Thank you.